Now, the next slide is going to be the most important slide. I'll spend some time on that. What are the risk factors for CKD progression? Now, so first, of course, the most important thing is the lifestyle factors. Now, each one of us have a different lifestyle. Someone walks 15,000 per steps and takes a vegetarian diet. On the other hand, some of you will go out and smoke, and I understand that smoking is pretty high in West Bengal. You will also indulge in alcohol in the evening. You will take a lot of salt. So, physical activity will determine how your progress is going to be. Then there are certain biomarkers. Of course, these are still experimental state, but still, if you do a urinary biomarker, you might find there are certain biomarkers which might show a positive trend in such patients. And these are the patients who are more likely to progress. Then I always say, you can't choose our father. We can't choose our father, but we can choose our father-in-law. So we can't predict our genetics. Our genetics will determine how we are going to progress in CKD progression. But definitely our lifestyle is the one which can save us. So there are certain these genetic predisposition to CKD progression, to RAS inhibition, to fibrosis, to inflammation. Now we have identified that there is a mesenchymal cells in the kidney which will convert into fibrosis, and that is the one which will determine the chronic kidney disease. And then there are certain genetic factors for our metabolism production also. Then, of course, the renal factors, a presence of a low GFR, a presence of a uropathy, obstructive uropathy in an elderly, presence of a glomerulonephritis, all this can predict how the progression is going to be. And presence of complications, anemia, metabolic bone disease, hyperkalemia, these will push the kidney dysfunction much further. And presence of a controlled high blood pressure, diabetes, autoimmune disease, gout, intermittent sepsis, all these can determine. And finally, do no harm. We are the ones who contribute further by giving them drugs, by giving them toxin, by subjecting them to unnecessarily CT scan that can also progress. So in nutshell, there are certain modifiable factors, there are certain various other factors which will contribute to the individual's progression of chronic kidney disease. And that is why there is a difference in trajectory of patients who go into CKD disease. Now, one very important factor, when I was a child, when I was studying medicine, I was told that patient develops a renal failure, acute renal failure, he recovers fully. But that is not so in this era. AKIs, subacute or acute, will cause certain amount of damage. And this is what is depicted by here. Say we have a patient with chronic kidney disease. He's progressive slowly. Suddenly he's developed one episode of AKI. His progression will become faster. His deterioration will become faster. And AKI severity will also determine how we'll go down in. And when he has multiple episodes of AKI, he's going to have further progression. So AKI and CKD are very interlinked with each other. AKI is never self-limited. It will always lead to some amount of renal damage. And if I ask you one question, how many nephrons do we have in one kidney? Can anyone answer this? How many nephrons or glomeruli do we have in one kidney? We have around 10 lakhs in each side, right? So if we have 10 lakhs in each side, as we grow older, at the age of 60, 70, our nephron number is reduced to 7 lakhs. Then each episode of AKI will reduce that number further. It may not translate to a decrease or increase in the serum creatinine, but it will definitely damage the kidney. And these are the factors: the old age, the delayed recovery, the severity, the etiology, and the comorbidities all will push an AKI to a case of chronic. And if a patient develops an AKI when you already have a low GFR, then the chances of this going into ESRD is much more higher. And how do we screen the progression? We need to, whenever we see a patient of CKD, we need to find out three important things. One is, what is his etiology? Try to find out the etiology. Is he diabetic? Is he hypertensive? Does he have what is known as a CKD-U? Does he have a polycystic kidney disease? Does he have an obstructive air? Second is, try to find out the GFR category and also write the albumin category. Based on these three, we can predict how is he going to progress. And we use estimated risk of occurrence of complications, and also we try to find out. And this is how we need to write. We now need to define CKD based on the cause, based on the GFR category, and also based on albuminuria category. You may have a person whose albuminuria, we no longer called it as microalbuminuria. We say normal to mildly increased when your albumin is less than 30 milligram per gram from 3 milligram, we call it as moderately increased. If the albuminuria between 30 to 300, and we call it as severely increased if the albuminuria is more than 300 milligram per gram of creatinine. And also based on his GFR category, we can divide them into G1, G2, G3A, G3B, G4 and G5. Obviously, a person with G3, 4B and A3 will have much more worse prognosis as compared to a person whose category is much lower. And as I said, we should also define him by etiology. And each one of you should have, you have so many apps on your mobile. You must also have an app of calculating EGFR. By downloading this EGFR calculator, you can just put the age of the person, the sex of the person, and serum creatinine, and you can find out the exact EGFR by these calculations. So, having talked to you about the etiology and the trajectory, are there any actual people come and ask you, Dr. Saab, what is your medicine? What is the nephrologist medicine which you are writing? ये तो sugar की बीमारी है, ये तो blood pressure का इलाज है, this is something else. Is there any actual medication which can prevent the progression of chronic kidney disease? And today, in my API JAPI journal, there is an editorial written by me on retarding chronic kidney disease progression, which is getting published today. Do we have a choice? And it is based on one of the original articles written by one of the authors from Kolkata regarding evidence of some particular drug. We'll talk about it on the prevention progression.